Good morning, everybody, and welcome on Saturday, the 5th of December, to our webinar. We'll just wait a few minutes so that we can get everybody into the session and comfy. Well, it's sunny in West Yorkshire. I don't know what it's like in your neck of the woods, but I'd like to welcome everybody here. Thank you for joining the first or the third of our second series of webinars for students. I'm Dawn Stott, the Chief Executive of AfPP. We have over 200 people registered today, which is absolutely fantastic. And some of you will already be members of the association, but for the benefit of those who aren't, we're the UK's leading membership organisation, and we're dedicated to theatre practitioners and improving patient care and perioperative care. And we've been around for over 60 years. So our aim is to enhance the quality of care and patient safety by constantly developing and promoting the leading standards. What are the benefits, I hear you ask, of being a member? Well, we've got a range of diverse member benefits, but supporting our members is at the heart of everything we do. And now more than ever during these difficult times. So we provide education, professional advice, legal cover to offer support with mental health and well-being. And we're doing our very best to assist members during the current pandemic. We've got our peer-reviewed academic journal, which is complemented by our IPP, which supports innovation and well-being. We also hold our popular, highly respected 3-day annual conference at York University, but I'm sure you'll all be aware that sadly we couldn't hold it this year. So it will take place in August 2021, where we'll be back even bigger and better than ever. We always attract amazingly good speakers, and it's a great opportunity to network with other professionals and representatives from the medical device industry. So membership starts from £5 a month for students, and you can find out more about that on the AfPP website. And also today there's an application form that you can download as a PDF as part of the session. You can apply online if you want to pay in full, but you need to print the application form off at the moment because we don't have that DD format on our website. Our Saturday sessions are a new benefit that we've introduced during the pandemic, and we've been overwhelmed by the response. And today's webinar is the last in our student trilogy of learning. But our next webinar, which is next Saturday, is a Christmas gift to everybody, and it's based around the Christmas carol: care, accountability, resilience, openness and learning. But today we're looking at a theme around theatre etiquette, which is a great reminder whilst informing newly qualified practitioners of how to behave, the things that to expect within that theatre environment. Just a little bit of housekeeping before we start. We've got a number of polls throughout the session, and your responses to those will be valuable to AfPP and to our speaker. And there's an opportunity to ask questions as part of the session, and I would encourage you to do that because we do put some time aside at the end of the webinar to be able to answer those questions. The chat feature is also live today throughout the session, so please use it. And I know that Julie will be asking questions and will hopefully be able to use the things that you chat back to us. We'll do our best to answer the questions either as we go through or, as I say, as part of the question and answer session at the end. Now, there's also a handout to download as well that complements today's learning. So it just leaves me with great pleasure to introduce Julie Weir, who is an ODP, a senior lecturer at Canterbury University, and is currently working at Canterbury Christ Church University as the Programme Director for the BSc paramedics, not parademic, that's a mixture of wrong words there, a paramedic science programme. So I'll hand over to Julie. Thank you, Julie.
Yeah, paramedic, you've got to get your head around that. I don't know how an ODP finds themselves running paramedics. It's not an easy gig, I can tell you. So yes, welcome to the webinar. I'm aware that we may have a mixed audience today, although predominantly it's likely that we'll have students. There may be some new practitioners as well. So I am aware of that, and I would try to tailor the event so that it meets the needs of everyone who's attending. Okay, so first of all, Dawn has sort of outlined the purpose of these events and what this session is about. So that this just summarises what the aims and objectives might be. and the bit about raising awareness of theatre etiquette and protocols and raising awareness of the standards, I would say to you that if you haven't already done so, or if it's a while since you've done so, do go and ask in the theatre manager's office or where the policies and procedures are kept to look at the theatre protocols and policies around all the different features of working and operating theatre, because it's likely that those are based on AfPP's standard recommendations. So it will really help to put what we covered today into context and to look at best practice. What I will say as a caveat for today's session is that I will cover, I'll go through the things as highlighted here in the aims and objectives, but I'm not going to talk about COVID specific recommendations and guidance. That's for a whole nother day. So the things I talk about are based on what normally happens and usual behaviours and etiquette in theatres and infection control and things. Another thing I need to point out is I have an African grey parrot called Charlie, and you can probably hear him waking up now. I can't control him. This is the best place for me to do my webinar, and even if I'm upstairs, his voice travels. So I do apologise for Charlie in advance, but I'm afraid he hasn't got a volume control, so sorry in advance. It seems an obvious question, doesn't it, to ask, why am I here? If you are a new student or a current student covering either as a student nurse or an operating department practice student, I think these sorts of events are really useful because it kind of reinforces what your education provider is telling you and helps you to prepare for when you're actually going to be working in that operating theatre. So I've said the things I will cover today, but I am interested really to find out if you have any particular personal objectives and why you have come to this session today. So what I'd like you to do is to just think about one thing you would really like to gain from today's session, and you'll see on your panel you've got the chat feature there. If you could just quickly type in the top thing that you would like to gain from this session, and then I would see if I can make sure that we cover that within the session within reason. So I'm going to give you a little bit of time to do that, and then I'll look at your responses. So I'll give you about 30 seconds, I guess, to do that. Oh, so I've got some responses coming in. Okay, yeah, so some good points coming in here. That's great. So Grace, yeah, so Grace is the first person that that commented. So Grace, you say that you would really like to feel more comfortable in going to the theatre the first time, and I absolutely agree with that. It can be a scary environment, and the first time you go in there, you feel like you're in another world. It is quite a closed environment, and all the things you see on TV and all the thoughts you might have about it don't really prepare you for when you actually first go in there. So yes, I do hope to definitely cover that during today's session. And then Jackie says, how best to learn whilst in theatre and not to get in the way. Oh, I just remember that so much as a student. Yes, yes, I'm definitely going to cover that. And then to familiarise myself with the operating theatre, again, that's Grace. Quality control methods. So Sue is asking about quality control. So I'll look at sort of the standards and infection control and sort of traffic flow, those sorts of things. So yes, I will cover those. And then Mihari says, I'm an anaesthetic nurse who has just started mentoring a new nurse, so just wanted to know what to teach her. Oh, there's so much to teach students, isn't there? But I think my answer to that would probably be professionalism. So I will go through some of those aspects in today's session as well. And then so I'm just reading the sort of first top 5. So the last one is just to have an idea of do's and don'ts within the theatre. Yes, absolutely, Sean. That I absolutely hear you there, because in those early days of being in the operating theatre, you may not feel like you're being useful, but at the very least, if you're behaving as you're supposed to behave and not getting in the way and following instructions, you know, that's part of the battle, really, isn't it? So some good questions there. Yeah, so I hope that through the session we should be able to cover those. Okay, so let's go back to my presentation. So I'm just trying to figure out how to get rid of the chat feature now. Hang on a second. So Dawn or Kelly, I'm not sure how to get rid of the chat box that comes up. Are you able to do that?
If you just drag the chat box to the side of your screen by holding onto the grey bar at the top.
All right.
Drag it to the side.
Okay. Yes, thank you.
Okay.
Okay. So let's go back a bit. Sorry. So yes, so in answer to some of your questions, I guess a good place to start is to think about what is the operating theatre like. So I'm going to show my screen now. So what is the operating theatre like? Let's go back to presenter mode there. And to the uninitiated, the first time you ever go into an operating theatre in those early days, it can seem to be like a really alien environment. It will have an air conditioning system, which is very efficient, but it can get quite hot in there. If you're the person scrubbed at the table and you're wearing a lead apron and a gown and the lights are shining down you, it can be very hot. If you're scrubbed for a long time, but also it can seem quite cold as well. So when the patient is anaesthetised on the operating table, often we will use bear huggers and warm air blankets and things to keep the patient warm. So it can get a little bit chilly in there. And if you haven't experienced already, it can be quite smelly at times. So there are some body odours that you will encounter in terms of pus and poo and other unpleasant things that come out of the human body. The smell of burning flesh from the diathermy is a common feature. And some of the chemicals that are used can be quite noxious to the nose as well, so it can be quite smelly at times. There are some top tips you will be given. So if there's a particularly smelly bowel case, you may see people putting lemon essence on their face masks and things to tolerate the smells if there's a nasty abscess. There are also hidden hazards within the operating theatre, slips and trips. There might be a lot of water on the floor. There could be x-rays, there could be laser. So be aware of those and just be aware of your environment and things that are going on around you, and follow the policies and procedures on health and safety as well. And I remember when I first started working in the operating theatre, I remember my very first day in the operating theatre, I did feel like completely at sea, because everyone seemed to know what they were doing, and they were all talking in this jargon. It was like a foreign language that I didn't understand. Lots and lots of abbreviations, lots of medical terminology, and I would be asked to set up the operating list, go and get ready for that patient. and it was gobbledygook. It made no sense to me at all. So that can be very challenging for the uninitiated. You might hear someone say, "Oh, send for the ORIF," or send for the MU8. Well, those are all abbreviations, and it does sort of dehumanize the patient a little bit as well, but you will hear these things. So don't be afraid to ask questions or to clarify what they mean when they're asking them, because you're a learner, you know, that's what you're supposed to do. In terms of the overall what's an operating theatre like, to the outside observer, I would say that sometimes it looks like a slick and well-oiled machine, in that things are going on in there. Sometimes there's not a great deal of conversation, but people just seem to know what needs to happen next. So a team that is working well together and are familiar with the procedures and to look out for when things maybe are not going to plan, sometimes imperceptibly the pace will change. So it can be quite slow. Long cases can, I have to say, can be a little bit boring, which you wouldn't think that would be the case in operating theatre, but it is. But then the pace will change, and you may not know why that's happening, but the team working in that environment know that maybe things are not going to plan, and so what we need to do now is this, this and this, and they're always thinking 3 steps ahead. So if you're working with the anaesthetist, for example, so when I'm working in anaesthetics, I keep an eye on what's happening in the procedure, and I know what I need to do next, but also I keep an eye on the monitor. Things start to change. Sometimes the anaesthetist will look up and say, "Can I have?" and I'm already giving him the thing that he wants. So it's that idea of this well-oiled machine working together as a team. And in the beginning, you won't feel like you're part of that, but eventually you'll get to understand the routines and the rituals and the rules. And you will eventually become part of that team. There will be things that will go wrong at times, but you will be part of that team eventually. I've put a little reference in there about the rules and rituals that you might observe, and I'll draw your attention to the reference from Woodhead. Oh, sorry, my parrot, Charlie. The reference Woodhead is at the back of the presentation, and that was a seminal report written by Kate Woodhead, who was really closely associated with AfPP, and they did some research about things that happen in operating theatres and where the evidence base has come from for the things and the behaviours and the rituals that are taking place. It was quite old, back in 2002, and I would say that was a game changer. And after that research came out, after that time, you now see that people don't always wear face masks, and sticky mats and overshoes and those sorts of things have disappeared because the evidence base for some of those rituals and procedures was not strong. So do take some time after this webinar to have a look at those, at that report. It does make quite interesting reading. So the last point to make there on that slide is it's hard to know who's who. Everyone seems to dress the same. They will wear name badges sometimes, or they might have them tucked down inside their tunic, and it can be a bit embarrassing not knowing who's a doctor, who's a nurse, who's an ODP, and it's a guessing game at first. So that can be quite confusing for the uninitiated. So having all these people working in this department, you'll have nurses, ODPs, support workers, you may have advanced scrub practitioners, you may have associate scrub practitioners, you may have theatre managers, radiographers coming in from time to time, surgeons, anaesthetists, and of course students, and you know, unless they have, some theatre departments have different colour clothes and things, or different colour hats to single people out, but you may not know what the system is first of all, so it can be quite hard to figure out who's who and who's the doctor. I mean, usually the person doing the operation is the doctor, the surgeon, so you'll get that bit right, but all the people around, it can be hard to figure out who's who. and figuring out where you fit in there can be hard as well, and not feeling like you're a complete spare part. That can be really hard in the beginning. But the point I'd want to make there really is to figure out finding out who's who. The most key thing we can do there is use something known as the WHO checklist. So it's that we use a 5-step to safe surgery, which I'll look at in a little bit more detail later on. But at the start of the day, using the WHO checklist, it's an opportunity for the team to introduce themselves, even if they work with each other every single day of the week. It's a chance to go around and say who you are, if you're a visitor, if you're a student, and while you're there today, you may have medical reps coming in, so they may be part of that sort of check-in. And it really does help to break down the barriers and to figure out where you fit into things. And if the team know that there are students in the room, you know, in that list on that day, then they'll have it in their mind, and they might then involve you or tell you things about what's going on. So using the WHO checklist is a really key benefit. And alongside that, if you are a student, it's likely that you'll be supernumerary. And if the team know that, then they won't be pressuring you to go off and get something complicated or get you involved in things if that's not really part of your role. And the other thing as well is to don't be afraid to find out whether someone likes to be addressed as Doctor or Mr. or their first name, because that can be awkward. Sometimes surgeons say, "Oh, just call me Chris or call me John." That can be difficult if you're used to calling them Mr. something or other. So the consultants are Mr. and the junior doctors are doctors, and that can take a little bit of getting used to. But you'll get there in the end. And my last question there is really to figure out who you think the most important person might be in theatres. So do you think it's the surgeon? Do you think it's the anaesthetist? Do you think it's the scrub nurse? Use the chat feature again and see if you can identify who you think is the most important person in theatres. I'm going to mute my mic while Charlie's singing, and I'll wait for your responses. So do put some responses in there. Okay, so that's very encouraging. I see the first response at the top of the list is the most important person is the patient. So well done, Stephanie. You've identified that straight away. If we didn't have the patients there, we wouldn't have a job for a start. And you must never forget that at the heart of everything we do, the reason we are there and the reason we are working there and who we're working for is not the surgeon, who may think he's God, it is the patient. So for those of you that put the patient as the most important person, that's absolutely a spot on. Well done. Okay, so moving on. So thinking about helping you with who's who and the dress code and accessories, as I mentioned earlier, there will be different coloured clothing and things to put in. So when you first arrive into the department, in the changing room that you go into, there'll be various tunics and trousers to put on. So they're usually organised in size order. So you cannot wear your own clothes in theatre. You will wear the tunics, and you're not allowed to bring in your own uniform and take home wash. These are all laundered centrally So it's not the same as if you were a nurse working on a ward where you look after your own uniform. You wear your scrubs for the day and then you put them in the laundry bin and they go off and get laundered. There may be occasions when you are expected to wear paper clothes. If you're working in transplant surgery or in orthopedics, there are disposable paper tunics and trousers that are available as well, so you'll be told if you need to wear those. Listed down the side, you can see all the different shoes and things that are made available to wear. So if you're going to be attached to a theatre department for as your base placement, or you're a new employee there, they will put an order in for you to get a pair of shoes, but be aware that you won't get those straight away, and it will take a while for the order to come through, so you might have to be wearing someone else's shoes for a while. You'll be instructed as to which theatres you'll need to wear a face mask in. So if you're doing orthopedics or a microsurgery or some other types of surgery, they would like you to wear a face mask. If you're the scrub team, you will wear a face mask and often a visor as well to protect you as sort of part of your PPE. There are different colour hats to wear, and those are used to denote sometimes if you're a student with your surgeon, there are hoods and things to wear that sometimes surgeons put on if they've got beards and things. So there are lots of different bits and pieces available for you to wear. But the point to make there is don't be precious about it, because in those early days when you haven't got your own shoes, the box of spare shoes is rather like the lost property box at school, and there are some pretty smelly shoes in there, so you might need to clean them down a bit before you start wearing them. Also, it's sod's law that often there's all the tops in the right size, but none of the trousers in the size that you want. So you'll either be squeezing into a tight pair of trousers, or you'll be having to really pull in the drawstring to make them fit you. So there are some ill-fitting clothes available in there. And the last point to make there as well is about jewelry. So we all like to wear our jewelry, but wearing jewelry is an absolute no-no in theatres, and there is an evidence base behind that, in that it can, if you're wearing lots of bling, it can scratch the patient. It can get in the way if you're lifting and manual handling. If you're scrubbed, definitely it can harbour sort of bacteria under your ring. So jewelry should be removed, and some theatres are stricter about this, and you will see some staff still wearing jewelry, but that doesn't mean to say that you should wear jewelry. So that is definitely a no-no. Do as you're supposed to do, not as you see others doing, I would say. And earlier I mentioned about overshoes. So we used to sometimes have a box of overshoes at the theatre reception for people to put on, but evidence has showed that the donning and removing of overshoes is worse. If you get that on your hands, it's worse than not wearing overshoes at all. So those practices have really gone out of favour. And lastly, you will see people leaving the department with a surgical gown put on back to front. You are not supposed to wear your theatre garb outside. Go down to the canteen, go out to the car park. Really, you're not supposed to do that. You will see that, and that's an example of poor practice. So read the policies and guidelines and follow those, and try to observe best practice, not follow those poor role models that you see. So don't be part of the problem, be part of the solution. And in terms of theatre design, when you first step into that operating theatre, you will see that the layout, it might seem strange. Why is it laid out the way that it is? And if you were to visit several operating theatres across the country of a similar age, you would start to notice that the layout and the design is maybe very similar, with the idea being that the operating theatre is designed in zones. So it's set out for public areas, sort of clean areas, sterile areas, and so on, and to aid the traffic flow. So when you first go into that department, do take some time to familiarise yourself with the traffic flow and how things run around the department, because that's all set up to aid the sort of maintaining infection control. And when you first go into that empty operating theatre, it does look quite big in there, doesn't it? It looks quite roomy, but actually when you get a patient in there, when you get the surgical team in there, when you get all the trays of instruments and all the other machines that go ping in there, it doesn't then seem quite as spacious. So it can get quite packed in there. And so part of that sort of clinical environment and that design is to keep the number of personnel in the operating theatre itself down to a minimum, because the more people are moving around and the more people jostling, you might then start rubbing up against the clean drapes or tripping over things and knocking against things. So try to keep the number of personnel down to a minimum, and also try to reduce the amount of moving in and out of the theatre as well, and be aware of when the patient is awake and if they're in the anaesthetic room. So it can get quite noisy in there at times, and the surgeon may have his Motorhead CD playing that he really likes. So it can seem quite a social environment, but tread carefully, I would say. Don't take that for granted, and be aware that there is a patient in there. There may be a patient and their relative waiting in the anaesthetic room or in the reception area to come in. So just to have that in the top of your mind. There are members of the public coming into this environment, and they're expecting professionalism and professional behaviour, and you need to be part of that. So being aware of your behaviour and where you're stepping and the way the traffic flow around the department is all part of that, and especially around maintaining infection control. So here's an illustration really of the typical layout of the operating theatre itself, and the peripheral corridor. So it demonstrates really this graphic. It demonstrates the flow of the patient into the department, through into the anaesthetic room, then where all the prep areas are for equipment and sterile trays, and then patient moves into the theatre itself, and in the middle where the operating lights are, that's considered what's known as the sterile zone. So you have these increasingly clean zones from outside to inside, and the ventilation system and things are set up so that it's most clean in the middle of the room where the patient is, and air is being forced down and then extracted through vents to keep sort of turbulence to a minimum, and to stop any microorganisms settling. So there is a method and a rationale for the way that the theatres are designed, but that needs to rely on several factors for it to be successful. So we now have a poll. Kelly, are you going to manage this poll now? Yes, so the poll is open, and I'm going to give you a little bit of time to think about what you think is the most important feature of operating design in order to aid infection control. So we're going to run the poll, and I'll wait for you to respond.
Okay, Julie, so the responses to the poll are, let me just get those for you. 72% said all of the above, 28% said staff compliance, and the rest, the other 3 questions, nobody responded to those. So 72% all of the above, 28% staff compliance.
Okay, so we're nearly there. So I can understand why some people might say all of the above, but I think the point I want to make there really is that you could spend an absolute fortune on designing a state-of-the-art operating theatre and have all those different things in place, but if staff don't comply with traffic flow, with observing etiquette in movement in and out of theatres, and crossing the sterile zone, all those features and all those things that have been built into that design would really count for naught, because if you don't comply with the things you're supposed to do to aid sort of implementation of infection control and to maintain the sort of the fields and things, that system will be compromised, and you may as well just be operating in a field, really. So there are ventilation systems, there are all sorts of things set up in place to help to aid infection control and to reduce the settling of microorganisms. But if staff are moving around and really not doing what they're supposed to do, and lots of turbulence, it will really affect the efficacy of that system. So I'm going to go back to my presentation now. I'll resume slideshow. Yeah, so that's be aware that you can have all of those things in place, but if staff don't comply, if they don't follow the traffic flow, if they don't observe the clean and dirty areas, even if you don't have a ventilation system, if you follow all the other things, it would help. So it is really staff compliance. And this little cartoon here is a little bit extreme, but it does, I think it does illustrate what can happen if staff don't comply with what they're supposed to do. So we see here, imagine you're that person in the middle doing the operation. It's a really tricky procedure and you need all your concentration. There's lots of chatter going on around you. That's going to really affect your concentration. We've got some people there taking photographs. Well, that is highly unprofessional. We see someone bursting in through the wrong set of doors and they're upsetting the airflow. We can see in the background little bugs waiting to come into the room as well. So it does make a difference, and just you may see other people breaching these things, but don't be that person. Comply. You should be part of the solution, not part of the problem. Okay. So that links us on really now to think about infection control, and I just want to gauge what you already know. So a question there, the poll is open. Who is responsible for infection control in theatre? So make your votes again and we'll see how you got on.
So Julie, the response is everyone, 100% of everybody watching.
Yay! Oh, that is really
everyone.
good. That's really good. Yes, you're absolutely right. It is everyone's responsibility. If you just think it's someone else's job, then we're doomed to fail. Everyone should be playing their part, even in the most little things. We all have a part to play in infection control. So well done. Yeah, that's absolutely fine. So go back to my presentation. Zoom slideshow. Okay, yeah. So well done. That's absolutely correct. So this leads me on just to, you've probably seen this this graphic or this idea of this chain of infection before, and this really illustrates how we've all got our part to play in maintaining infection control. So in order for infection to spread, and I'm not going to mention the COVID word much, but we can see how this is playing out in the pandemic. There needs to be a source of infection, and there needs to be some way of spreading that infection, whether that's through sort of direct contact or through airborne, respiratory, and so on. And then you have your individuals at risk, so people who are immunocompromised, the older patient, very young babies, the surgical patient, who has got an open wound, so the portal of entry needs to be there as well. And if you've got all of those things linked together, then it's possible, if there is some infection, then that could spread and actually end up causing an infection in the patient. So the way that we can break that chain is the method of spread. If we observe infection control policies, wash our hands, make sure our instruments are clean, make sure we observe single-use items and so on, the method of spreading, how when we're dealing with patients or body fluids and staying clean and observing those things, the method of spreading is going to be reduced. The portal of entry, so you'll observe that not everyone gets a catheter these days. Doctors used to say, well, yeah, put a catheter, more for the convenience of the staff, I guess, in the past, but there needs to be a clinical need for catheters and in cannulation technique, observing clean technique when putting cannulas and putting drips up and things. All of those things, if you observe good infection control policies, you can't always reduce the numbers of portal of entry, but if you try to keep things as clean as possible, that will reduce the chances of things getting in. So then coming towards the end now, the last few things to consider are around ethical and legal consideration. So even if you are a student coming into the department, this is going to be your base placement, you will still have sort of rules and regulations to abide by. If you're an ODP student, for example, there is a guidance on conduct and ethics for students that you should be aware of from HCPC. So we all have a responsibility to behave professionally. We are ambassadors for our profession and for our university, perhaps if we're being placed into an area by our university. So and everyone has a scope of practice, and even if you're being asked to do something, you need to be aware of what your role is, and don't be afraid to say, no, I'm not happy with that, or I don't know if I should do that. Doctors don't always know what ODPs and nurses, what their role is and what they can and can't do, and you'll sometimes see people think, oh, I think that maybe they're acting outside their role, but don't be bullied into being part of that. If you're working with an anaesthetist and they suddenly ask you to make up some complicated infusion with lots of different drugs into a drip bag, I would argue that's not your job, that's the doctor's job, and don't be afraid to say, I'm not comfortable with that, or I'm not sure about that. I think that's, we all have a level of accountability. Even if you're not a registered practitioner, we are all accountable for our actions, and we are advocates for the patient, and that patient is very vulnerable, and our actions or inactions have consequences. So we all have a part to play there, whether we're a nurse or an ODP or a doctor. We all have our own scope of practice. And in working in the operating theatre, you will have access to sensitive information through the patient's case notes, through the computer systems and things that are being used. And you should be aware of the GDPR and issues around patient confidentiality. So what you see, what happens in Vegas stays in Vegas. Do not talk about it in the pub. Do not go home and tell your friends all about the things that you've seen. You know, you as part of your professional behavior, you should observe patient confidentiality and be aware of the sensitive information that you will see there. So do read up on the various pieces of legislation around that and the policies in theatre regarding that. Though it's likely that you'll be asked to sign a disclaimer or sign up to observe patient confidentiality. So you'll need to read further around that. And part of the legal side of things, the issue around consent. So when I first started as a student, the consent form was one-sided A4 piece of paper. It basically said, I state your name, do consent to having whatever the surgeon deems appropriate. Really, that was found not to be fit for purpose. So consent forms are quite detailed these days, and there is an AfPP standard around that, which will give you more guidance about gaining consent and issues around consent, and where consent starts and when it stops, and things about mental capacity and things as well. So for further reading, I think that's one of the handouts and things that's been made available to you, but I've referred to it in the references. So if you go into your theatre department and look at the policies and procedures, you will find those relating to consent. So do take some time out just to read up on the theatre policies around consent. And linked to that, I'm not going to go into a great deal about the Human Tissue Act, but part of that consent is consent to what happens to body parts. There were some high-profile scandals in the late 90s and early 2000s about patients' body parts being retained, and it hit the press, and it caused a change in the law. So patients need to be part of giving consent to what happens to their specimens, what happens to organs or tissue that's removed from them, and how it is stored and disposed of, for example. So that might be an area of further reading for you. But overarching all these things about the ethical and legal consideration, we need to have top in our mind that that patient in the operating theatre is completely reliant on us. They are completely vulnerable when they are anaesthetised. They cannot protest, they cannot change their mind, they cannot even move their arms and legs. They are absolutely reliant on us to look after them and take them safely through their surgical journey. The way that we position our patient, if you're in bed at night and your legs in an awkward position, you will move it. The patient cannot do that. We have to be thinking about that patient all the time, and look after them, or put them in cotton wool and make sure they make it safely through the other side, and act as a patient advocate for them. So I'm going to ask you now whether you to give a definition, I think, of what you think it means to be a patient advocate. So again, use the chat feature and just first thoughts that come into your head. What does it mean to be a patient advocate? Yeah, so I see there's some really good responses coming in. So Shelley, I think you've hit the nail on the head there. You say looking after someone and being responsible for them when they are unable to do that for themselves, speaking up for them when they're unable to. So if you see, I had an example once where a patient was coming in for a hernia repair, and both sites had been marked, but it wasn't spotted until the patient was anaesthetised, and the surgeon wanted to go ahead and do the hernia repair, but there was a sense of doubt in the team. What if we do the wrong side? And so I was scrubbed at the table at the time, and I had to kind of put myself in the way, and I didn't want to give the surgeon the scalpel because I felt uneasy about it. So it is about really speaking up for them if they're unable to yeah, so it's putting yourself sort of in harm's way almost to stop harm happening to them and to speak on their behalf. We think about advocacy in law, you know, a lawyer or a barrister speaks for their client, and it is a bit, you know, knowing what things are supposed to be like and being aware of how things are supposed to go. And if you spot something or you feel that the procedure is going not according to how it should go, or it's going off piste, and you feel that the patient could be harmed or you're uneasy about it, you can stand up for that patient and put yourself there and say, no, I'm uneasy, I think we should take stock, or I think we need to consider what to do about this. So yeah, absolutely, some good responses there. And then lastly, I said I would just finish on 5 steps to safer surgery. So the WHO checklist was introduced in the early 2000s, or 2009, 2010. And I remember when it was first introduced, I was working in a private hospital at the time, and the surgeons and the anaesthetists, they all poo-pooed and said, what a waste of time, why do I need to do this? And there was hostility as to why it was being used. So but now I've just been doing a return to practice course, working again in another private hospital, and in that 10 years I think people have absolutely seen the purpose of the WHO checklist and how it can be beneficial, and it really is, you know, you wouldn't an aeroplane wouldn't take off and head for Spain until all the checks had been done and people were sure that all the checks had been done. And it's a similar principle, really. So in safer surgery, just being sure that everyone knows who's who in the room, briefing, planning, anticipation. Is a particular bit of kit going to be needed? Is there a particular prosthesis that's going to be needed? Is there an issue about the patient that the team needs to know about? Who's in the room at the time? Oh, we have a student here today. Okay, well, we'll look out for you and we'll explain as things go along. If there's a medical rep coming in to do a demonstration of a piece of equipment, then we know who's who in the room at the time. So planning, briefing, and so you have like almost like a team huddle before the day starts. And then the sign-in before induction of anaesthesia, just checking that all things are in place and all the checks have been done to the patient. So checking the consent, checking the site, checking allergies. The anaesthetist should confirm with who is with them in the anaesthetic room that's been done. And then the timeout, so before the operation actually starts, ensuring that all the things are in place, that the bear hug is on, the diatherm is there, everything is as it should be. So another checklist. And then towards the end of the operation, before the patient leaves the room, making sure all the checks have been done, all the documents have been signed, the register has been signed, everything has been done. And has there been any untoward incidents or things that didn't go to plan, or any worries or concerns in the debriefing session before moving on to the next case? And so it has taken, I think it's taken a good 10 years, but if you go into a modern operating theatre nowadays, you will see the WHO checklist in practice and working as it should be. It's taken a long time, but it does now work. So the last thing I want to show you then is the AfPP guidance on 5 steps to safer surgery, and I think this is being made available as a handout for you, and it just gives you some sort of detail about what the different steps are and what's to discuss, and some of the comments and challenges you might observe around these stages. It needs for everyone to be doing their part and being part of the who checklist. If people poo-poo it or they don't believe it's worthwhile, then it won't work properly. So it needs for everyone to be on board, and really it should be the doctors, the consultant anaesthetists and the surgeons who are leading that process. They need to be on board, and then the team is on board with them, and anyone else who's there in that theatre at that time is part of it. So don't feel that you're not part of it. You are part of it. You're in that list at that time on that day. You each have a part to play. So do take some time to read up further on that, and observe how it works when you're in theatre. So observe how closely people observe the guidance and the steps in the procedure. So just to summarise, the very last thing then, just to summarise, as we've gone through the presentation, you know, I think I've helped to highlight, to be successful in this unique environment, it's a unique opportunity to work in this closed world. My top tips, I guess, would be follow instructions. Don't be afraid to say, I don't know, I'm new here, I'm not quite sure. You're going to feel like a numpty a lot of the time, but you'll get there eventually. Follow instructions, take advice. People will have different ways of doing things, and eventually you'll develop your own way of doing things based on best practice and based on what you've read around. Engage proactively and enthusiastically with the environment. Don't just stand there like a spare part. People would just work around you and throw a green drape over you or something and get on with their day. So be part of the team and be involved and show your interest. And you know, you will not have your phone in there, but you know, you're learning, so be part of that. Always be professional and courteous. I don't think that being over familiar or being over chatty won't win you any friends. And you are representing not only your profession, so if you're a student ODP or a student nurse, you're representing your future profession, but also you're coming from your university, and so you're representing your university, so you need to be an ambassador for both. Be aware of accountability, where your accountability starts and stops, where your role starts and stops, and if you want to get on, make friends with the theatre staff. Some of them will be a bit hostile at times, and sometimes tempers can get frayed when the going gets tough, but ally yourself with theatre staff, ODPs and nurses, and you know, you'll have a mentor there, but you won't get to work with your mentor all the time. So just, you know, be part of that team, and try to follow a patient through all phases of their journey, so you can see how the system works and what happens to that patient as they work through. A brilliant top tip I would have, and I would advise all my students, keep an ongoing reflection of your experience and progress, so you can look back and see what it felt like when you were first there, and where we are now, and how you have moved on in that time. And the last point to reiterate is always remember that the most important person in theatre is not that surgeon who thinks he is the most important person. It is the patient, and we are there for the patient. Okay, so just to very last slide, references and further study. I have put some links in there, and I think the presentation will be made available to you. So these will take you to the links to the sources and things. So I've put the reference for the AfPP standards and recommendations, and theatre etiquette and things, which are available as a handout for you today. And then that key piece, that key article that I talked about, which is a bit dated, the Woodhead one, but is fascinating reading. So that concludes my presentation, and I'll hand over now to Dawn and to Kelly.
Thank you so much, Julie. Really informative. We do have some questions, so I'm going to just whiz through a couple of the questions because I'm very much aware of time. We have had Kim, who's asked, as a new ODP student, how to deal with different people's personalities.
Oh, that's a tough one, isn't it? I think, you know, a truism is there will be some battle axes of all grades that you'll come across within a theatre environment, and there'll be I don't know, grumpy anaesthetists and grumpy surgeons. It can be hard and it can be scary as well, and you'll get shouted at. You're not a punch bag for a bully. Do not put up with bullying behaviour, but at the same time, do appreciate that when things are not going to plan, or you've got a time critical case on the table, a tricky procedure, sometimes tempers can get frayed, and to show understanding and be aware of what impact you're having on that situation, I think is key there. And there are times to ask questions and times to make comments. Choose your moments, I would say, and learn from the responses that you get.
Great advice, thank you. Anu has said, first of all, good morning, everybody. I've been a scrub nurse for more than 18 months in the UK, and I'm now going for in-house training as a surgical first assistant. So the question is there any specific theatre etiquette for being a surgical first, for being SFA, moving from scrub to SFA?
I think in terms of etiquette, I think you just need to be aware of I think the biggest thing there is being aware of your scope of practice. You are not a surgeon. Your role starts and stops at a certain point, so you need to be aware of that, and don't be afraid to advise a surgeon where your role starts and stops. So don't be afraid to say no if you feel it's something outside of your scope of practice, or something that's outside of your boundaries of competence. I think that's probably the advice I would give there. And read the guidance, the lovely guidance that's provided by AfPP.
Thank you. We do have a lot of guidance in our standards and on the website. And there's one thing that I would like to mention. We do have a new book, and I think Julie's referenced it in her further reading. It's a student's guide, and it's brand new. It's just been rewritten, and it's there on the website. And it does have a lot of the theatre etiquette background in there, as well as mentoring and who you need to go to and things like that. So there's a lot of information in there, so have a look out for that on the website. Lucy's asked, can you explain the hierarchy of doctors? Who is an SHO and what is the registrar? Can you answer that one, Julie?
Okay, so when a medical student qualifies, they become, well, I don't think they're called a house officer anymore. There are more modern terms, but it used to be they'd be a house officer. So that is just like a complete, the paint's not quite dry behind the ears type doctor yet. And then they become a senior house officer. So they after a certain time of working as a junior doctor, maybe they've taken other assessments and they then become what's known as an SHO. And then they do their locations and their placements around, and they think about what they're going to specialize in. So you may have an SHO in surgery who is doing some time working in surgical practice. So an SHO is a junior doctor. They're unlikely to be leading on surgery. They may be assisting in surgery. And then as they go through their career, if they're deciding they're specialising in surgery, they then need to take a series of exams. So you hear the F1, and they do F1, F2, and they do certain waypoints that they have to get through to become what has traditionally been known as a webinar. It's been known as a registrar, and then they become a sort of a senior registrar, and then that's up to consultant. That's how it works. It used to be that it was a long, hard slog. We see people becoming consultants at a much younger age than they used to be, and the junior doctors' hours have changed and things over time. But that's how the system has been in place.
Thanks, Julie. Do you think that they're looking younger because we're looking a little bit older? They say that about policemen.
No, I think the routes of progression and the way that the system works has changed over time, hasn't it?
I'm sure. I'm sure. The final question: the best way to get the most out of my placement, from Stephanie. There is a lot of this in the new student book that I've just mentioned, but have you got any hot tips, Julie?
How to get the best out of your placement?
Yes.
I had a little bit of you faded out a little bit there.
So how to get the best out of your placement?
Okay, so really to get the best out of your placement is to go in. If you've been assigned a sort of named mentor, or you're going to be working in a particular speciality within the theatre department, whether that's anaesthetics or surgery, or in orthopedics or in obstetrics or something, then ahead of your placement, take some time to go and meet your mentor or contact your mentor. Go with your placement objectives. Fill in your documentation about what you want to get out of the placement before you start your placement, not at the end of the placement. And you are responsible for your paperwork and for working towards meeting your objectives. So have that discussion with the staff that you're going to be working with. Think about where your strengths and weaknesses lie and what you'd like to concentrate on, things maybe you're not confident in, and review that. Identify some time to review that with staff that you're working with on a weekly basis. And I think that if you keep an eye on what you want to get out of the placement and bring some focus to that placement, you've got more chance of achieving those outcomes.
Excellent. Thanks, Julie. And I'd like to thank everybody for joining us today. We've had 100 people on the webinar, which is absolutely fantastic. Julie, you were ably assisted by Charlie in the background, which was quite unique for one of our webinars, which is fantastic. I'd also like
I've had him at exam boards and all sorts of things.
I'd also like to thank Grace and Kelly, who are my Charlies in the background, I guess, looking after me and making sure we're kept on track. There are some handouts to download off the site, so please use those. They complement the learning that you've had today. I'd just like to finish by saying thanks again for joining us. Please stay safe, look after yourselves, and watch out for the webinar next week. It's going to be a good one. It's Jules Wyman in conversation around the Christmas Carol. So thank you, everybody. Lovely to not see you, but I know you're out there. So, and Julie, thank you.
Okay, thank you very much.